Good morning, everybody, and thank you for having me today. I think Susie and Lorna have really nicely framed my talk. It's fascinating to hear about the work you've done and looking at the priorities of children and young people, and interesting to see how psychological support is so important. I'm a psychologist. It looks like we have rather a big task. And so my interests are in supporting young people with a psychological impact of particularly paediatric brain tumours. I'm also a neuropsychologist, so I'm also interested in looking at brain function after brain tumours and their treatments, particularly the impact upon cognition, by which we mean intelligence, memory, all aspects of thinking which allow us to function in day-to-day society. So today I'm going to talk about the neuropsychological difficulties experienced by childhood brain tumour survivors, but also other cancers that have treatment to the central nervous system often experience children with those cancers, such as leukemia, also experience some of the difficulties I'm going to talk about today. And my mission really is to think about how we better understand and therefore prevent this harm caused by brain tumours and their treatments. I noticed that in your top 10 questions, at least 3 or maybe 4 of them were referring to late effects and survivorship, which is my area of focus. And particularly I want to talk about how we work together collaboratively. So the theme for this year's conference is about breaking boundaries, about creating partnerships and improving outcomes. And I think that's so important. And the work I'm going to talk to you about, it's about collaboration overseas. Guy has already talked about how important it is that we work together internationally, because we don't have enough participants in our local centres in the UK even to do good research. So we rely on working with our international colleagues, and I'm going to talk about some of the relationships we've built doing that. Also between professionals working on quality of survival include psychologists, oncologists, neurologists, radiologists, and of course families. And really our partnership with families is the key to success for our research, because without them we couldn't do this. Lots of families engage in research in the interests of their children because they want the best treatment and the best chance of survival for their children, but they also do lots of things over and above that to help us altruistically create better futures for other children. So the quality of survival in children is so important because children aren't yet fully formed human beings. They're still developing. They're developing their identity as a person, and they're still acquiring skills and knowledge. If you are an adult and you sustain injury to your brain, the likelihood is you'll still be able to read because you've already learned to read. But if you're a child and you sustain injury to your developing brain and you have poor attention and poor memory, that then makes it very difficult for you to learn to read and to acquire a whole host of skills that are going to help you to function in later life. We've talked already about the impact on education, on fertility and future career. And so the doctors that are making very difficult decisions about the best treatment routes for children face a very delicate balance about increasing the possibility of cure for this child, but also what sort of life this child will then go on to live in the future. And many of the children we see have multiple risk factors, and we're going to go on to talk about what they are. So here are some of the late effects of childhood cancer. There are many more, but those underlined in red are those that psychologists are working on currently, and in particular I'm going to talk today about intellectual function and intelligence. So these are some of the difficulties the children and the families that come to see me clinically talk about, and there are many, many more. But all of these interfere with how a child can function in school and in day-to-day society, how they can get themselves organised to even get to school with the things in the bag that they need, and how they can make friends along the way, and how they can really just get through the school day often, and how they can take part in other activities after school and participation in society, all of which have a huge impact upon mental health and quality of life. So if I can get this to work, because we had some problems with it earlier, this is Madeline. She is a brain tumour survivor, one of our patients at Nottingham. And she also suffered posterior Fossa syndrome, sometimes also known as cerebellar mutism. And this is a post-surgical complication when shortly after surgery, children's motor function, their movement and their speech can suddenly be very impaired or lost. It requires very intensive rehabilitation. It's very distressing for children and their families, and it's associated with quite significant long-term difficulties. Okay, so that's Madeline. I'm sure you agree she's beautiful, and her mum very eloquently explaining some of the difficulties she's experiencing. So that was a video made by Jimmy Teens TV. That's a short clip for it, but it's available online and talks all about posterior Fossa syndrome if anybody is interested in learning any more. So there's various research out there summarising some of the difficulties children experience. This one goes on to look at things like attention, memory, visuospatial abilities, executive function, which I'm going to go on and mention a little bit more, and processing speed, which was also mentioned by Madeleine's mum. And this has an overall impact on academic achievement, independent living and quality of life. Executive function describes a whole set of more complex skills that allow us to succeed from just starting something, initiating an activity, taking part in something, whether it's starting homework or taking part in going out to see our friends or a sport, inhibiting our impulses. This is really important to help us to be socially civilised, because we have all sorts of urges to say and do things on a daily basis that we manage to hide quite well from society. If you can't hide those things and you blurt out the first thing that you're thinking, or that you or perform the first action in your mind, this makes it really difficult for you to integrate into society. Persevering on tasks, organising and planning, this is a really big issue in school. Being creative or flexible and being able to monitor and modify one's own behaviour, again really important for friendships and sustaining relationships. Another review here goes on to list the numerous difficulties, and really the point of this slide is it includes pretty much everything. When you injure the adult brain, because the brain is more mature, you can have a specific injury to a part of the brain, and that leads to a specific deficit, such as finding words. This doesn't happen in children. The brain isn't so well differentiated and organised. The brain is developing, skills are developing, so you tend to have a much broader impact across a whole variety of different areas. And some of the research shows, particularly children who have early radiotherapy, there can be an IQ point drop of about 14 points, sometimes more. And so this is our IQ. I'm sure all of us are at the end 130 because we're all really smart. The average is 100. The bottom of the average range is about 85. So with 14 points, you can take somebody from the low average range, where they'll be able to sustain skilled employment, into the learning disability threshold, which is 70, which is hugely significant. So that could be the difference between somebody being able to hold down a good job to not being able to work or make themselves a sandwich. So when we talk about the impact upon intellectual outcome of brain tumours, and particularly our treatments, it's really very important. And there are several risk factors we know about. We know that if children are younger, if they are treated with more intensive radiotherapy and certain types of radiotherapy, if they have hydrocephalus, if they have seizures. There are numerous factors that we know increase the risk, and these are the things that we need to understand more about. And we know that in children who don't have brain tumours, who have things like hydrocephalus or seizures, that they already have cognitive problems. So really this just illustrates the number of risk factors and how this is compounded for many of the children that we work with. So the challenge for me is to think about how we can better understand and therefore prevent the harm caused by brain tumours and their treatments. Particularly the treatments, because we can't change the fact that the brain tumour has occurred, but we can think about the impact and better understand the impact of our treatment, which later informs choices. So CEOP is a worldwide organisation, but CEOP-E is the European component of that brings together professionals to work together to improve the life of children with cancer, and hosts a number of trials. Very, very important collaboration. It's not always easy because in different countries they have different ways of doing things. Here are all the countries that are part of CEOP. As you'll see, it's a really wide range. And within CEOP, we have the quality of survival group. So this is a group of people who are particularly interested in looking at how survivors experience life after treatment, to monitor these issues, and in particular to look at how we measure this in the trials that are going forward. So we're saying, whenever you have a trial, can you please make sure you're measuring the quality of survival? What sort of measures are you including? So Mathilde, who's from France, Gabby from Germany, and Jenny from the UK were the past chairs, and Pablo and Jürgen from Germany and Belgium, and also myself, but you can see what I look like. We are now the current chairs, and we're working together to make sure that all the trials include appropriate measures of quality of survival. And it's difficult, it's stressful, there are endless debates about the best way to do things. The tests that we use, so the tests we use to measure, it's often children sitting down doing different exercises. We try to make it fun. They're not all translated into languages, the versions aren't all available. Germany tend to use different sorts of tests to measure the same things as we do. So there are endless debates about the best way to do this, and to do this in a way that doesn't increase the burden on the child. So it's hard work, but it's really very rewarding work. And I'm going to give you an example, which is the current ependymoma programme. So ependymomas are the second most frequently occurring malignant tumour, and they present significant challenges. The graph that Guy showed us at the beginning that showed that not all tumour survival rates are increasing, well, ependymomas are some of those tumours that are really quite difficult to treat and where the prognosis really can be quite poor. So this is an international programme looking at improving the accuracy of the diagnosis. So there is a central panel that meets, a national panel, where the scans and histology are reviewed to look at agreement on the diagnosis to increase the accuracy, and there are different therapeutic strategies. But importantly, there's been an agreement to reduce the age at which we're irradiating children. So previously in Europe, less so in the US, we've tried to avoid exposing the brain to radiation at a very young age. And we've lowered the age at which we're doing that from 3 years to 1 age, which increases the risk of long-term outcomes. So it's really important that we include good cognitive follow-up in this trial. So here is the trial. There are stratum 1 to 3. The first is for those under 12 months. A lot of these children are very, very young, you'll see, where surgery has been very successful. There is no residue after the surgery. And they're looking at the efficacy of a post-radiation maintenance chemotherapy. So after the conformal radiotherapy, there'll be maintenance chemotherapy in one of the groups. The second group is for those over 12 months where there is some measurable inoperable residue. And they will go on to have a frontline chemotherapy up front before the radiotherapy with or without methotrexate. And then they're looking at the safety and efficacy of a boost of radiotherapy afterwards. And the last one is for the very young children under 12 months who are not eligible for radiotherapy. And they're looking at a chemotherapy study with or without valproate, and there's also an observational study, and you'll see the centralised imaging review at the beginning, which is really bringing together people across the country to work together. Okay, and these are the countries. There's about 18 countries so far, but not all alive yet. And these are the UK centres. So within CEOP, the Quality of Survival Group published a paper which helped us agree on measures we're going to be using on trials, and this emphasised the importance of both direct and indirect measures. So our success so far, and the way we've done this up to now with some great work by Colin Kennedy and Kim Bull, is giving families questionnaires, looking at how tired the children are, their health symptoms, and that's what we've done on our trials so far. And those are some of the things in measure. What we are now introducing, and this is the first time we've done this comprehensively, is direct measure. So this is us sitting down with the children and actually measuring this, seeing what they can do, not just asking the parents their perception, but direct measurement with children in the local centres. And we're doing both of these things, which is the gold standard. We're doing this at baseline. This is diagnosis before treatment, because we want to see where these children are at before they then go through our treatment, so we can help us to understand the impact of the treatment and isolate the effects of the radiotherapy, for example, from difficulties that children may have had anyway due to the presence of the brain tumour. And then we're doing that at 2 years and 5 years, and also hoping to do it at 18 years old. Because it was so difficult to agree on a set of measures across Europe, because people use different tests, there are different translations, and also because centres are very differently resourced, there's huge discrepancies in the availability of resources in local centres to do these, we have developed this Core Plus battery. And this is a way of ensuring we have a minimum data set. So we're saying that we've agreed on these are the things that are most important to measure. So if you've only got 40 minutes time, if the child only has 40 minutes, your psychologist only has 40 minutes, we'd like you to do the core battery in the middle. But if you're someone with lots of centres, say, well, that's not enough, we want to do more, we want to measure executive function, we want more detailed assessment of memory. If you've got time to do those things, then great, then you do the plus bit on the outside. So we don't have people doing bits of things and then a really messy data set. We have a core data set and then a smaller, more detailed data set. And what we've now done is we've increased this to prioritise the tests in the middle. So if you've only got 10 minutes, everybody starts with the first 2. So our data set becomes much more cohesive. And what is interesting about the way we're doing this is it's clinically integrated, so it's not centralised. So we're relying on the psychologists in the local centres who are seeing these children clinically. People like me, we do these assessments with children to work out where they're at, what their difficulties are, and what sort of support they might need in school, and to help them with strategies. So we're aligning this with what's happening clinically, but we're asking the psychologists to use a standardised set of measures which are very similar, if not the same, as what they'd use already, and we've thought that through quite carefully, and to do it at set times and to share their data with us. There was a lot of talk about this not being possible. We're not having the resources to do it, and that's why the questionnaire approach was developed. But actually, it's been more successful at baseline, which is the most difficult time to do this because children are sick and families are distressed, and there's not very much time because they're going for an MRI, or they're not feeling well, or they're asleep, or they're getting plane tickets to go for proton therapy overseas. We've actually got about 71% attainment, so 71% of children have completed some form of assessment. It's a little bit messy in terms of the data sets because we've got lots of partial completion because some people still don't have all the tests. But that's really promising. And so we have a research assistant in Nottingham, Mrs. Darren, funded by Cancer Research UK, who also funds some of my time. And his role is to bring all this together, to phone the centres, to email the centres saying you've got a patient registered, these are the things you have to do. So we're not relying on people's interpretation of the protocol and answering their questions. And you can see how much that's improved our adherence. In the first year, when it was slightly chaotic, we had 50%. In the year we had Darren, we had 83%. So you can see how much that has improved adherence to the protocol and how important that's been. So before I move on to that, really, I'm just really delighted with the success of this and would like to see it rolled out to more trials. We can see here there is no reason why we cannot directly assess children's abilities before they start treatment, and therefore throughout their journey and their survivorship, which gives us a much better indicator of how children are doing, and it will help us understand the impacts of the treatments. So to take this a little step further, one last thing that we're doing is, so earlier in the year, no, last year, I was invited to go and talk in Washington DC with Christy Hardy, who I'd never met before, and we were invited to do a presentation together on how we measure children's quality of survival, particularly in neuropsychological aspects in brain tumour trials. And we decided to do a collaborative presentation, which was a challenge because we'd never met each other and we're preparing it other sides of the world. And what we learned is how we were really quite logically facing similar challenges, how we'd come up with quite separately the same solutions or similar solutions, but how we'd also thought of things or developed methods that each other hadn't, and therefore how much was to be gained. So what we've now instigated is a global consensus paper. So we're getting together, Christy and Karen are from the Children's National, Leanne's a psychologist from San Antonio, Pablo and Jürgen, Pablo's a neurologist oncologist and Jürgen is also a psychologist in Germany and Belgium, and then with Colin and Kim, who've done all the great work on the quality of survival questionnaires, and Professor Richard Grundy, who is an oncologist in Nottingham, who has been hugely supportive of incorporating these psychological measures on trials. So we're putting together a paper looking at how we should be measuring these things across the world and how we can work together doing so to improve our understanding of how our treatments are in fact impacting quality of survival. So we've learned that our new test model is feasible for measuring intellectual function after brain tumour treatment. It can be applied to other national and international trials. We're now about to publish consensus for how we measure this in children under 5, and we're going to use a similar Core Plus model with core measures in the centre and more detailed assessment where feasible. And we hope that this will inform future treatment choices to reduce the harm caused by childhood brain tumours. So just want to say thank you to all the families taking part, the local psychologists, Cancer Research UK for their funding, Darren for all his hard work, and Professor Grundy for his support, and of course the CCLG are hugely supportive of research into the late effects of childhood cancer. So I'd like to thank them for that and for inviting me here today. Thank you.